Welcome to the St Emlyn's podcast. I'm Iain Beardsell.
And I'm Simon Carley.
And Simon, it has been a while since we have had a chat on the podcast and gone through some blog posts. There's been a lot going on, still a lot of podcasts coming out, lots of other activity, but it feels like forever since I last spoke to you. It was way before Christmas. We're actually going to be recording October's blog post today, and we are recording in January. This is poor form from us, but there are reasons, and let's call them excuses. Simon, how are you?
Very well, actually, thanks. We're having a good time. Life is good. It was actually sunny outside in Manchester, as it often is, of course, and I'm just waiting for some snow.
Snow may be coming, and I'm very much looking forward to the Big Sick, where we will both be in a couple of weeks. There will be snow in Zermatt, I'm almost sure. An excellent conference, sold out already, so we don't need to do a big selling job of that. But we could mention Incrementum 2026, which is in April, which is a bigger auditorium, bigger audience, and so does have a few spaces available. Simon, we've extolled the virtues of Incrementum before. We probably don't need to say too much, apart from for new listeners to the podcast. But this is a cracking conference in Merthyr, some top quality speakers, top quality tomatoes, a great time to be had by all, and not that expensive.
No, it's a great group of people to get together with, all of like mind about resuscitation and emergency medicine. So yeah, if you can get out there and you can afford and you get the time, I know that's difficult for some people. Yeah, go for it.
So that's Incrementum 2026 in Merthyr in Spain from April the 22nd to the 24th. Nice cheap flights available from the UK. I was looking just earlier this week. An excellent lineup. And more than that, Merthyr is just a great place to be. Some great food, some sunshine, just what you need to think about in these dark grey days. Search it out and you'll be able to find it on Google. And Simon, since we last spoke, I have finally launched MedPod Learn. Listeners to the podcast may well have heard me bang on about it already. I'm going to bang on it slightly now, but this is the app that I've been spending all this time designing. It's basically a curated medical podcast library, but with some extra tools on top. Free download from Google Play and App Store. Simon, you've had a play with it and you've been very kind.
Yeah, no, it's been great, actually. And I think the way that you can log your CPD, I think was a bit of a game changer. It's much easier to work out. I've listened to this podcast, I can get something out of it and record it and put it in a portfolio, which is nice.
Yeah, dead easy. So if you're listening to this podcast on MedPod Learn, it will automatically record your listening time. There's some learning tools you can use afterwards. And then with a single click, you can download all of that activity, all of the podcasts you've ever listened to, the MCQs you've answered, the reflections you've written in a single click into an Excel spreadsheet to pop in your appraisal folder and satisfy all of those CPD needs. So trying to hopefully fill a gap, which means podcasts become even more useful than they already were. One other thing just to mention, a huge congratulations to our friends and colleagues at the Resus Room who have just passed 10 years as podcast producers, producing some of the highest quality medical education I think there is out there. Simon, Rob and James all do an amazing job. Not least, they get it out regularly and it's always high quality. There are over 7 million downloads, which as a podcast creator is a phenomenal amount to understand what that really means for a small team like that. And they are constantly producing quality. I'm sure listeners to St Emlyn's are familiar with Resus Room, but if you're not, give it a listen. Always brilliant, great back catalogue, and huge congratulations to them again from all of us at St Emlyn's.
I completely agree with that. And also, they're lovely people.
Very nice people. Simon, let's crack on to some emergency medicine after all of that preamble. Let's talk about some of the posts that we had in October. Little while ago, but then again, a lot of this stuff is still relevant and will be relevant for months to come. And if it's okay with you, just because I'm in a trauma mindset, we're about to go to the Big Sick, can we talk about the factors in the initial resuscitation of patients with severe trauma, the first trial first? It seems a good place to start, doesn't it, with the first trial? And this was a blog post you wrote, and this is all about bleeding patients in trauma and what we use for their clotting factors and blood replacement.
Yeah, so the background, of course, is that in severe trauma, particularly patients who are continuing to bleed, then managing the coagulopathy, which is associated with that, is really difficult. It's really complex. And also, if you get it wrong, it's highly associated with their mortality. Any patient in whom you're activating a major hemorrhage protocol, so the patient you're giving blood, O-negative blood in the resus room or pre-hospital, that's the group of patient you've got to be worried about. And there's been talk about how do we replace the blood clotting factors? Because, of course, the red cells, the bag of red stuff isn't blood, it's just a bag of red cells. And it's pretty pathological. We've done other blog posts on that. But how do you replace the clotting factors? And in the UK, our most common thing to use is FFP. And that's what we use in Worcester, as what you use down south, isn't it? But there are alternatives, and people have looked at things like fibrinogen concentrate and prothrombin complex concentrates to see if we can use that, because these are basically bags of clotting factors themselves as opposed to the full FFP. And there's been a few trials in that in the past. So cryostat was out there, and another trial called ProCoag, which looked at fibrinogen concentrate or cryoprecipitate and fibrinogen getting into the patients early. Both of those are negative, actually. I didn't show any particular benefit. But this is a different trial. This is in Canada. It's at 6 level 1 major trauma centres across Canada. And it's an RCT, which is exactly what we want to see. And they compared in their major hemorrhage patients, giving them 4 units of FFP as part of their process, or 4 grams of fibrinogen concentrate and prothrombin complex concentrate. Follow those patients up. And the major outcome was use of blood products. Now, I think you can argue that the use of blood products is not a particularly patient-related outcome, but if you're trying to manage your coagulopathy, I suppose as a proxy measure, it's reasonable. And it's also fairly straightforward to measure, I suppose. The randomized patients, they had 217 patients in the trial, and essentially they didn't show any benefit. So in terms of number of units that they used in the first 24 hours, an average of just under 21 if you gave fibrinogen concentrate and PCC, and 23.8 for FFP. So slightly less if you gave the complex and the fibrinogen concentrate, but not statistically different. And the numbers they looked at, they stopped the trial because basically the chances of there being a significant difference if they ran it further, there was less than 1 in 4. So in terms of my practice, I use FFP now. I'm going to carry on using that up until the point where I've got more information, either from TEG or other clotting studies, ROTEMs, etc. And then I can nuance it a little bit more. Quite like FFP. It's got quite a few advantages, and it's been shown in quite a few trials to really make a difference. The more concentrated clotting factor type things haven't really shown the promise that they have in the labs and the problems they have in sort of animal studies when you put them out into the live world.
So if you want to read that full paper, and as always, we will always say, and we may as well start the new year reminding everyone that don't just believe us because you heard it on a podcast or you read it in a blog post. Always go back and have a look at the paper yourself. This paper is called Factors in the Initial Resuscitation of Patients with Severe Trauma, the first 2 randomized clinical trial. And you can find it in JAMA Network Open, Volume 8, Number 9. And of course, if you read the blog post, all the links are there, so you don't need to even work hard to find it. And lovely to see Andrew Protrozoniak, an old friend of St Emlyn's, on the author list there. So another bit of trauma, but not major trauma, is the management of upper limb injuries. And you've done a blog post on something I regard a little bit as history, but maybe I'm wrong. This is about using a Beers block. And I haven't done a Beers block for ages. And reading this really made me think about how I'm doing my reductions for fractured distal radiuses and what I should be doing. But this is another paper which you reviewed. Do you want to take us through this one?
I used to do quite a lot of Beers blocks, particularly in a hospital called Stepping Hill Hospital, which had a really great system whereby you come in, have your fracture, and come back the next morning for a Beers block. We used to love doing that. We had image intensifiers in A&E and to check the manipulation, all done within the emergency department setting. And these kind of fallen off the perch now. We don't do that so much. And if I see any patients now who require any manipulation, I think probably like you, I'm giving them intravenous sedation, propofol plus fentanyl or something like that, and then giving it a pull down in the emergency department. But not everybody's doing that. And there are some patients in whom sedation isn't ideal. Beers blocks are really good and give you fantastic analgesia, but they do have some associated risks. You need the equipment, it's a bit of a pain, you need the space and the time, et cetera, et cetera. An alternative is to do a supraclavicular block. So this is a local anesthetic block. They call it a supraclavicular block in the paper, but essentially this is a brachial plexus block. Inferior to the clavicle, posterior to the subclavian artery, plexus lies. And you can inject local anesthetic there. And it gives you really good analgesia pretty much for the whole limb, really, from that sort of axillary nerve area down. So that was this trial, really. Not the most difficult block in the world to do under ultrasound guidance. It's an open label trial. It's pretty small, just 78 patients. And they measured the pain, which is the major outcome I think we're interested in when we're doing a reduction, between the Beers block versus the supraclavicular block. And essentially, there was no difference. The pain score was so low that both of them worked really effectively. The block was scoring 0.1 on a 10 centimeter scale, and the Beers block 0.6. Absolutely fantastic. So essentially, what this trial tells us, even though it's small numbers, it probably does tell us that you can use a supraclavicular block as an alternative to a Beers block if you need to.
As you say, my preference has been to do sedation for these patients. And I think we got pretty good at getting departments set up to use fentanyl, propofol, or a combination of whatever you like to do sedation. And that can be a really good way to get nice comfort for the patient and to facilitate doing the procedure. Obviously, at the moment, all year round, sometimes resus rooms are busy and therefore you can't get in to do the sedation. And resus rooms for us in our department are the only place where we can do the monitoring required to do proper procedural sedation. Now, the downside to this paper really is that resus is the only space we have to do other procedures too. even if the patient doesn't need resuscitation. Our department doesn't have a procedure room. And so having space to do an ultrasound and to do a Beers block end up in resus as well. And so resus become our default procedure room. And now that is really causing us a problem. And I am finding patients are having to wait longer or get admitted to go to theatre to have these procedures done.
Yeah, I suppose if you're doing ultrasound guided nerve blocks, you should have them on monitoring anyway. But I agree, you don't need the same degree of monitoring as you do for sedation. I was also going to mention there's another block, which is not in this paper, but I did learn when I was out with some Australian colleagues, really good guys, about the supracondylar block. So that's blocking for distal radial fractures alone. And in this study, they looked at radius and ulnar. But if you're just looking at distal radial fractures, a supracondylar block, taking out the radial nerve just above the elbow. I've used that a few times now with variable success. It certainly has an impact. It certainly reduces the pain. I don't think it gives you the same degree of complete absence of pain as a superb trial has shown for the block and for Beers. But yeah, that's also worth looking at. And we'll put the link up for that in the blog post as well if you're interested in looking at supracondylars.
So if you want to read the paper, that's a supraclavicular block for emergency reduction of upper limb injuries versus Beers block, the superb trial. And that's in Emergency Medicine Australia. And that was done in several centres in Australia. Always great stuff coming out of a lot of the emergency departments down under. And congratulations to them as ever for getting this sort of work done. So that's a little bit about trauma, but often at this time of year, Simon, we do think about our emergency departments and how they're working. And Stefan Bruns has done a series of great posts about how EDs function. He's really very thoughtful about this topic, and I know he's involved at a national and regional level to try and help departments improve their processes. And he did a post about designers repair and what emergency medicine can learn. And also he's put in the title and why it is so hard. And this is a little bit about that ongoing innovation that seems to be happening all the time in departments, trying to find the quick hit silver bullet that will solve all of our problems. And he makes the argument that actually, instead of trying to redesign everything, sometimes repairing is something we could be concentrating on. This was really thought-provoking for me. I have to admit, I'm a bit long in the tooth and had so much to do with this process stuff in previous iterations of my career that now I struggle to engage with it. But I know for many of you, this is really important. I know Simon, as Dean of the college, this is a huge topic. Was there lots to take home for you from this blog post?
There was actually. And Stefan's looked at a guy called Ron Bronson is where he got this designer's repair concept comes from. And if we can just try and articulate it, and it's quite difficult to summarize the whole blog because there's so much good stuff in here. But the core argument is that the core argument is simple but fairly radical. The most important part of any system is often the person who keeps it from breaking today. And I read that and I thought, do you know, that's absolutely right. We work in so many systems which aren't perfect. And it's actually due to the people in it and the innovation and the innovation at individual level and actually effort that we put in that actually keeps things working. And you see this in our senior clinicians day in, day out, nurses, doctors, paramedics, everybody else. I thought it was really interesting. And systems don't just fail, do they? They don't just fall over in one day because of one thing happens. So therefore, it's not particularly radical to think that just not one thing is going to make it all better again. And it's not in here, but there's I think it's Chris Moulton. I might be wrong on this, but I'm fairly certain it's Chris, who has mentioned many times that lots of hospitals have transformation teams. These teams of people who come around and transform systems. And he said, it's not really transformation, is it? Transformation is when something like the wheel is invented. That is transformative. What most transformation teams do and what most hospitals try and do is make minor changes, which may over time, may incrementally change things, but it's rarely utterly changing. So the dominant logic seems to be in healthcare that we need more innovation, better optimization, breakthrough solutions, all of that. And instead, Bronson and Stefan argues that what we need to do is stop, look around, and see and support and design for the repair work that's already happening, to really find those people who are holding things together, to really try our very, very best to support them. And when they're doing things well, actually give them the space and the time and the resources to do it. So I thought it was really interesting. And it was a philosophical change for me because I see so many people knock on my door to say, if you just do this, then it'll be all so much better. And as you say, you're long in the tooth, Iain. But we know that isn't the solution. The white knight coming over the horizon saying everything will be better if you just do this rarely works. And we need to invest in the people and the work that they do.
It is incredibly frustrating at times, isn't it? Where there are little solutions that if we could just make them work, would seemingly make everything a little bit better. We just put a new EPR, electronic patient record, in my hospital, and it means we're at computers a lot more. And a lot of the keyboards we use, the keys don't work. or the mouse wheel doesn't scroll. And they've spent tens of thousands of pounds on a software solution. But when I suggested maybe could we get some new keyboards and mouses that work, oh, we haven't got any money for that. And you think every day I'm trying to find a keyboard, I'm choosing which computer to work at so the keys work and I can type full words and not just ones without vowels in them. And these little things are the bits that I really struggle with. If only we could just fix those little bits. When it comes to IT systems, a great old colleague of mine, Mike Clancy, who was also the dean of the college and president, he once said to me when I was putting in a previous IT system, he says, I'll tell you what, Iain, Bill Gates wouldn't put up with this shit. And he's not wrong, is he? Sometimes you just think it just needs somebody to come and fix it. And all of these repairs we're doing, if we could put those together, maybe that would be an answer. But we've got to keep smiling, keep going to work. And actually, one of the reasons that I keep going to work and one of the things I find most gratifying is medicine. And let's think a bit more about some medicine. Greg Yates has done a post for us about cardiac arrest. And as I've said before, I do think the management of particularly VF or arrhythmogenic cardiac arrest is where we can do better. There's lots of evidence coming about what we're doing. I know that when we're at TBS, Sheldon Checkers, who's the author of the dual sequence defibrillation paper, will be there. Hopefully we're going to grab him for a podcast. There's all sorts going on. But Greg does talk about 3 quick hits for cardiac arrest. Were these papers you'd known already, Simon, or was this news to you?
No, so I think these are 3 hits, but they're sort of exploratory, but they're worth reading through because they get me thinking as well. One was an animal study looking at using CPR directed by the end tidal CO2 as a marker of the effectiveness and also the diastolic blood pressure. And we talked a lot about how diastolic blood pressure is something we should be aiming for increasing in cardiac arrest because that is more likely to get ROSC with a target of about 30 millimeters of mercury. Got a systematic review coming out about that fairly soon. End tidal CO2 is a different one, but that's also obviously a marker of perfusion. So that's good, aiming for an end tidal CO2 more than 1.3. And that was associated with lots of positive outcomes. So if you can't do your diastolic blood pressure, maybe targeting your CPR to an end tidal might be good. And there's all the same sort of things that you can do, changing the drug doses, changing the position of CPR, moving things around, et cetera, et cetera, et cetera. So that was interesting, but not a game changer, but definitely of interest and chimes a lot of other things that go on. The second one from Spain was an observational trial looking at different forms of ventilation, bag of valve mask versus manual and mechanical ventilation versus chest compression synchronized ventilation, which is CCSV. I think it's only available on one of the types of ventilators, and that synchronizes the ventilation to the CPR. So it gives low volume ventilation in timing with the cardiac compressions. And I've seen some early observational data that suggests that's really good from other places, notably in Ireland. But in 521 patients, they showed observationally benefits to the CCSV over mechanical ventilation and BVM. Again, it's not an RCT, it's observational, it's of interest only. But there's a link on there to Cliff Reed's talk about the importance of managing respiration in CPR and cardiac, and the management of cardiac arrest. And CPR is cardiopulmonary resuscitation. But if you think about most of our teaching, we really pretty much ignore the ventilation aspects, the pressures, the volumes, the rate, what we're aiming for. It's all about the cardiac stuff. And Cliff really argues very well, in my opinion, on that link and on that great presentation that if we don't manage the pulmonary aspects as well, we're going to get much worse outcomes. And the last one, again, observational study, only in very small numbers, was about using cerebral oximetry, about whether or not that can give us an idea about whether we're going to get a ROSC and successful outcomes, because obviously perfusing the brain is a good idea. And in this very small trial observational data, they suggested that it was positively associated with ROSC. Advantage of that one is it's a non-invasive test. So it only takes a very short period of time to apply to the scalp, and it gives you an idea about how you're doing in terms of cerebral oxygenation. So I want to see more. I want to see proper trials. I want to see randomization, et cetera, et cetera, et cetera, et cetera. However, really interesting things to look at, which chimes exactly with what you said, which is we have not sorted cardiac arrest out yet. There's a lot more that we can do. And there's an awful lot of patients out there, I think at the moment, this is my opinion, there's an awful lot of patients out there who are dying of their cardiac arrest who do not need to do. And we can have some much more and greater numbers of positive outcomes if we do better.
And just to clarify what I think we both believe, we're not talking about people who are dying from long illness here. We're talking about people who have sudden cardiac arrest from probably arrhythmogenic cause. There are some toxicological causes where we're talking about cardiac arrest in the younger, physiologically better patient. But this is not about flogging older people who are dying. This is about a cohort of patients where we can make a real difference. And I really hope that if 2026 brings nothing else, it brings us the ability to recognize that those groups of patients are different, and the different strategies we have towards that can also be targeted to those patients.
Yeah, and the attitude I'm trying to instill in people now is if you're in a public place and you don't have a load of comorbidities and you fall over and you've got an arrhythmogenic cause, so you're in VF or VT for your cardiac arrest, you should survive. As a society and as a healthcare system, that's what our aim should be.
I think I said on a podcast maybe last month or the month before that it's a bit like the we're going to land a man on the moon. I completely agree that nobody in 10 years' time should die from an arrhythmogenic cardiac arrest. And that's where we should be. And I think that's a really valid target and one we could achieve. If you want to read those papers, they're all in Resuscitation, easy to find. As ever, the references are on the blog post. And just to mention Cliff Reed, always a joy. He will be in Murcia at Incrementum 2026. And frankly, it's probably definitely worth the admission money on his own. So if you want to hear Cliff speak, and if you live in Europe, it's less and less likely, what with him living in Australia now, then head to Murcia and you'll get the chance to experience a bit of Cliff Reed magic. Only a couple more left from this month, Simon, but it's been a pretty full month, October, actually. Stefan again did a paper just about suspected sepsis with broad spectrum antibiotics and are we over treating people? I've always believed that getting antibiotics in quick is one valid thing to do, but there's no point doing that if it's the wrong antibiotic. And I think this paper probably confirms what I believe.
Yeah, in summary, it's observational stuff. It's in a paper in Clinical Infectious Diseases. And they took 600 patients who'd been given broad spectrum antibiotics or antibiotics in the emergency department, and had a look back and thought, actually, was there really good evidence that these people actually had sepsis? Yes or no? And were they given what would be an appropriate antibiotic for them? And the headline figures are at least 30% of the patients they thought probably didn't really require this, or it wasn't really an infection anyway. And if you added that group of the patients to the group of patients who were given inappropriate antibiotics, so essentially largely meant that they were given broad spectrum antibiotics when they could have been given something which was directed to the infection source, that rose to 87%. So overall in the cohort, you could say that 87% of the patients were overtreated, although they recognize that it's difficult in the early hours of seeing someone. So maybe in reality, we won't get it to completely zero, but we're certainly probably overtreating. And also that 1 in 6 of the patients who were given broad spectrum antibiotics had some form of complication attributed to the antibiotics. So this is not and that's another thing, isn't it, Iain? Giving these drugs at the front door makes the numbers look good. And the sepsis team can come around and say, pat you on the back and say, great. But they're not the people dealing with the complications of this later on. And we have to balance this. We don't want to do a lot of harm by just hitting a target.
And we could probably get that made into T-shirts, couldn't we? We don't want to do a lot of harm by just hitting a target. And emergency care is one of those places where we do get obsessed with numbers and slightly less sometimes with actual patient experience and quality. It's something to think about. And I was pleased that this reiterated what I'd always thought, which is pause, make sure you got the right antibiotic and get that in a timely fashion. Don't just give anything as fast as you can. If you want to read the paper, that's in Clinical Infectious Diseases, and you can find the full reference on the blog post. Simon, that's a fly through October's papers. We will still need to keep going on another day to catch up with November and December. There's been a whole load of great stuff on the blog. And as ever, as we start a new year, if you're interested in writing for St Emlyn's or you'd like to contribute in any way, we would love to hear from you. You can use the contact us form on the blog post. If you would like to review us on any of the podcast creators and all that stuff and subscribe, that's great. Even better if you download MedPod Learn, because hey, supporting those little ventures will be lovely too. Simon, it's great to see you. I think the next time I see you, it won't be on a screen at all. It may well be across a coffee shop table in Zermatt for the Big Sick. Very exciting, very lucky that we get to go. And if you are going to the Big Sick, please do come up and say hello. We're actually putting together the first session of that conference. And so it'd be great to see you there. And we'd love to meet you and chat more about all things resuscitation and perhaps a little bit about snow and skiing. And we'll see you then. Take care.